Before going into a non-union, I wanted you guys to know about what is delayed union. So basically, union is considered delayed when the healing has not advanced at the average rate for the location and type of fracture, usually three to 6 months. This is according to Campbell. So according to trauma Crawford, when the fracture has not completely healed in the time expected, but still it has the potential to heal without any further intervention, it is called as delayed union. So now coming into non-union. So what is non-union? When the fracture has completely failed to heal in the expected time and it has no likely to heal without new intervention, then it is called as non-union. So what is the factor going which is predisposing for the non-union? We can divide it into systemic and local. So systemic causes will be nutritional status. So when there is a vitamin D deficiency or calcium deficiency, it can cause non-union. And metabolic status like diabetes and renal failure is also an important cause for systemic complication. And general health condition and a poor activity level, not exposing to sun, or any history of smoking and chronic use of NSAIDs and steroids are all the causes for systemic non-union. And coming to local, so if you see a patient with an open wound or if there is an infection, it is more common for non-union. And the fracture pattern, basically segmental fracture, which is a bad fracture which usually impairs the blood supply, usually at the middle fragment and into pieces. Comminuted fractures is all local causes for the non-union. And if patient has been previously operated and if it is not insecurely fixed or it is not properly fixed, then it can go for non-union. And if the patient has been operated and if patient is not been mobilized at all, if patient is bedridden, immobilized for a long time, and for this can go for local causes for non-union. And any ill-advised open reduction or any distraction either by traction by plates and screws can also cause non-union. And any fracture of the irradiated bone can also cause non-union. So this is the tabular column showing causes of disturbed bone healing. Four major things will be poor vascularity, which is biological. Instability means it is instrumentation or blood supply related. So poor vascularity can be because of traumatic and iatrogenic. Instability means because of the previous operated surgery not done properly, inadequate stabilization, or because of the bone resorption at the fracture site, even in simple fracture can also cause. And infection is always an important cause for non-union. So other things can be as I said before, diabetic, chronic alcoholism, smoking, and inappropriate weight bearing, all these are causes for non-union. So coming into classification of non-union. So non-union can be classified based on site, whether it is diaphyseal injury or metaphyseal injury. If it is metaphyseal injury, intra-articular, extra-articular fracture. So usually that can be divided into intra-articular, extra-articular, and depending upon the callus formation, whether the non-union is what type, atrophic or hypertrophic. Usually atrophic type, there will be a complete blunting of the bone edges. In hypertrophic, there will be a callus formation, but it will not be potential for the bone healing. In infection, you always find out whether it is aseptic or infected. So in this picture you can see, you get a non-union hypervascular type. There is two things, hypertrophic and oligotrophic. In hypertrophic, it is divided into basically elephantic foot and horse foot. In the first picture A, you can see, this is the horse foot type, and this is the this is the elephant foot type, and this is the horse foot type. And in avascular non-union, you can divide into atrophic, and it can be because of the defect, or you can see a huge defect here. So this defect can also go for non-union. So as if you go into diagnosis, history wise, you always ask symptoms. What is the patient presenting symptoms, and what is the current functional impairment and their demand. So if an old patient, non-worker, or a bedridden patient, it's not ideal to fix the fracture and make them bad. But if it is a young individual, you can always go and fix it. And functional requirement, and always take history about the initial velocity of the injury and the initial treatment what they have undergone, whether they went for any native treatment or like that, or initially it was an open wound, always that should be asked. And any comorbids, and what are the current medication they are on, and social history, any history of TB or something like that. And any factors for occult infection like open fracture, delayed wound healing, wound discharge, or any multiple operation has been done. So all this history are very important. And never forget clinical examination in non-union. The main thing is limb segment with adjacent joint. Whatever non-union side, always check the whole segment and always the adjacent joint also. And limb stability, any previous wounds, scar, sinus, anything is there. And what is the limb length? So after surgery you have to attain the limb length also. And neurovascular examination is very important. And what is the functional current impairment also should be documented. So diagnosis is based on history, clinical signs, and clinical sign main is pain and motion at the fracture site. So if there is no progress in healing, then it is called as non-union. So early diagnosis of delayed union is also very important. So what are the early diagnosis of delayed union? Swelling, redness, pain, implant loosening, irritation the callus with absolute stability. So now coming to treatment. Treatment should always be focused on four things: principle of treatment, stabilization, and how we are going to enhance the biology, and how we are going to eradicate the infection. So basically established non-union, always if it is in hypertrophic type, you have to consider three things. If already there is a nail, exchange the nail and put a bone graft or additional plating. Atrophy type means it is basically a biological problem. So exchange nailing, bone grafting and additional plating. And coming to the most complication of the non-union, compartment syndrome. So compartment syndrome is basically an elevation of the interstitial pressure in a closed osteofacial compartment that results in microvascular compromise. So it is a condition in which circulation within a closed compartment is compromised by an increase in pressure within the compartment, causing necrosis of the muscles and nerves and eventually of the skin because of the excessive swelling. So it is basically classified into acute compartment syndrome and chronic compartment syndrome. So acute compartment syndrome because of any fractures or soft tissue trauma or arterial injury or limb compression during altered consciousness and burns, and any intravenous fluid extravasation and or use of the anticoagulants. And in chronic compartment syndrome, it's basically a recurrence of the increased pressure, most often in the anterior or deep posterior compartment of the leg. In the upper extremity, basically in the heavy weight lifters, rowers, welders, and a pressure in the non-compliant compartment, exertional compartment syndrome of the lower extremity is common in long distance runner and military recruits. So what are the symptoms of the compartment syndrome? The 5 P's: pain, pallor, paresthesia, paralysis, and pain on passive stretch. Most important sign is pain out of proportion to the expected with the injury. What is the pathophysiology of the compartment syndrome? It is basically insult to the normal hemostasis, basically increase in the tissue pressure and decrease capillary blood flow and local tissue necrosis caused by the oxygen deprivation. So what is the treatment? Treatment is basically a single incision fasciotomy or double incision fasciotomy depending upon the level or which compartment the pressure is on. Thank you.